So, Bismillahirrahmanirrahim. I welcome you all to today's session. As usual, I'm going to give a small introduction, then we will start. So, we know that I can do things that you cannot, but you can do things that I cannot, but together we can do great things. So, that's why we are socially connecting in the era of this social distancing. And this is the endeavor of Oncology Club to connect colleagues so that we can talk, discuss, and educate ourselves. So today our session, how should I treat my patient following evidence-based medicine? Today our faculty is Dr. Mostafa Aziz Sumon, who is a very bright oncologist. And the only introduction that I want to give that in 2012, I told to one of a very senior colleague that the day will come when he will cross me. And I'm very happy that already he has crossed me and he has a long way to go. So he will become a wonderful oncologist. Already he is, and he will become a much bigger oncologist. And we have three overseas faculty. Dr. Zakirullah, he is a senior. Dr. Farid, who is a junior. Both of them are son of this soil. You all know them. And we are especially grateful to Dr. John Conivier, who spared his holiday to give time with us. And I'm very sure that his participation will enlighten us. Thank you, John, for participating. So already I talked about Mostafa. Now, our patron and inspiration is Professor Hai. We all know that he is the president of Oncology Club, and he is the person who is always inspiring us to go forward. So I will request Sir to officially start the session so that we go to the next portion. Sir. Hi, sir. Can you hear me, sir? Hello.
Yes, sir. Thank you very much. Thank you very much. Sir, without waiting for any, we should start now.
Thank you, sir.
Thanks everybody, particularly the faculties from abroad, Sumon and all the participants from my core of heart. Let us start now. So we're talking later.
Thank you, sir. So we took some feedback, and according to the feedback today, we have some information to share. We have increased the time from 60 minutes to 90 minutes because last week it was scheduled for 60 minutes, but it ended in 120 minutes. So we wanted to make it 90 minutes in between, and we want to be very much in time. Presentation time will be 15 minutes. We will have, in different course of time, we will take comment from three foreign faculties in 15 minutes time. And the question, answer, and discussion, we will allocate 30 minutes. Case discussion will be 20 minutes, quiz 5 minutes, and vote of time and wrap up is 5 minutes. So this is how we will try to stick on this time, and so that we can maintain the time, not to make it boring for others. And another thing, I want to today make some small rules. Say, we want to identify the participants. Who are the faculties? All three foreign participants are our foreign faculties, and locally, whoever is assistant professor and above, they are the faculties. And who are the participants then? Participants are anybody having a post-graduation or a postgraduate students, they are the participants. So why these three groups? This group is because we want to make a participation policy, because we all should not be asking questions and participating. So what we want, that faculties, especially the local faculties, will primarily respond to the question. Whenever we, moderator, will identify who will answer, and you can volunteer that you want to answer by raising your hand. And participants, your job is to ask the questions to the faculties. You should volunteer for the question answer session and also for the case discussion and rapid fire session. And send anybody, either a faculty or a participant, if you have any question, please put it in the chat box. And then we will bring it on and we will bring for discussion. And quiz is open for all. And if anybody have a very personal, very high profile question, we appreciate if you discuss in chat box rather bringing it into the platform. So now I ask very quickly, Masoon, give the analysis of our last session, what we did in last session, what is the feedback?
Sure, sir. We can please
screen share here. Masoom, it is not coming.
You have any problem?
Okay, Masoom, do you have any problem? Then we keep to it later.
Yes,
And
yes. That's better.
Okay, Sumon, can you start the presentation? Today, we have a presentation from Dr. Mostafa Aziz Sumon. His presentation is on neoadjuvant chemotherapy. So, Sumon, can you please start? Whether it is an option or a necessity, that is the question that we will be talking today. Sumon cannot hear you. Sumon, please unmute yourself. Okay.
Whether you can see the screen? Screen is
Yes.
okay?
Yeah, everything is fine. You can go ahead.
Okay. Thank you. Thank you, Dr. F.M. Kamaluddin. I mentioned him as my elder brother, Kamal Bhai, for those nice words. But I am really not capable of this high words. So come to today's discussion, neoadjuvant chemotherapy for breast cancer, option or necessity. Let me introduce first. I am working as assistant professor in Kurmitula General Hospital. In a private sector, I am working as a consultant in United Hospital. And from today, I am joining in Austin Mission Hospital as a consultant. Now come to the main topics. So before going to the main discussion, I would like to quote a very popular quotation. If you want to stalk someone hates, put in a sequence of 3. So in the next slides, considering the neoadjuvant chemotherapy, we try to keep it in mind the rule of 3. To come to the point, so in neoadjuvant chemotherapy, what we really want to know, there are 3 points, 3 issues. Number 1, why? Why we need this neoadjuvant chemotherapy? Number 2, who? Who is going to get this neoadjuvant chemotherapy? And number 3, which drugs and which duration? So first come to the question, why? So traditionally breast cancer was treated with surgery, then neoadjuvant chemotherapy. Then why this neoadjuvant chemotherapy concept came? So there might be some rationale. Who? So every breast cancer patient is not going to be treated with neoadjuvant chemotherapy. So there might be some indication, there might be some stratification. So who are those candidates? If you are going to give this neoadjuvant chemotherapy, everybody should not going to get the similar type of drugs. So what should be those drugs? And what should be the duration? Should we give 4 cycles followed by surgery, followed by 4 cycles like the old sandwich techniques, or we should give all those neoadjuvant chemotherapy before surgery to get the optimum pathological response? So these are the 3 main issues that I am going to cover in my earlier discussion, next discussion. So now come to the first point, why? Why we are going to give this neoadjuvant chemotherapy? So here the rule of 3, there are 3 answers. Number 1, neoadjuvant chemotherapy improve surgical options in respect of breast conservation rate or R0 resection rate. So whenever we feel that surgery is a quite bit difficult in respect of breast conservation surgery, we can give neoadjuvant chemotherapy. For those who are initially inoperable, this neoadjuvant chemotherapy can convert this case, and ultimately it can produce a good R0 resection. Number 2, not only the surgical conversion, it also reflects in the clinical response rate. And at last, the main important issues, it can produce a good pathological complete response rate. We will see in my future slide that the pathological complete response rate is really a game maker. So neoadjuvant chemotherapy, whether it produce any survival benefit, wait, we'll try to see in my later slides. So this is the NCCN guidelines. You can see who are the candidates for this preoperative or neoadjuvant chemotherapy. So again, you need to keep in mind the rule of 3. For inoperable breast cancer, those who are initially inoperable, we need to keep in mind the 3 main subset. Number 1, inflammatory breast cancer group, N2 and N3 axillary nodes, and those who are T4 tumors. So we need to keep in mind the 3 points: inflammatory breast cancer group, N2 and N3 axillary nodes, and the T4 tumors. These are those patients, who are initially inoperable. Neoadjuvant chemotherapy can downsize the tumor, and we can have a good surgical result with this neoadjuvant chemotherapy. For those who are operable, even these groups may get some benefit with this neoadjuvant chemotherapy. So neoadjuvant chemotherapy is not only for those inoperable groups, because in operable breast cancer group, it facilitates breast conservation. And still, we need 3 subgroups of these operable sets. Number 1, HER2 positive disease, TNBC, if the tumor is more than 2 centimeters, or N positive tumor. Any large primary tumor relative to breast size should be go for breast conservation surgery. Opted for breast conservation surgery, we need to give neoadjuvant chemotherapy. And any node positive disease that the consultant might think that the neoadjuvant chemotherapy might turn this node in a negative status, this patient can be offered neoadjuvant. So in operable subset, any tumor that is apparently bigger comparative to his breast size and patient needs breast conservation surgery, we can offer neoadjuvant chemotherapy to facilitate the breast conservation. Any HER2 positive disease, any TNBC, tumor 2 centimeter or not positive, she should be offered with neoadjuvant chemotherapy. So again, we should keep in mind the rule of 3. Regarding the NCCN and the ESMO, the European are very popular with this neoadjuvant concept. As you can see, the NCCN guidelines say that the T4 tumor, but here you can see in the ESMO guidelines, they have mentioned that the tumor more than 2 centimeters, you can offer this systemic induction therapy. If the patient is in TNBC or HER2 positive tumors, 2 centimeters or not positive, you should offer systemic induction therapy. So, with all the sum up NCCN and ESMO guidelines, we can sum up as follows: that any T4 tumors, any not positive tumors should be offered with neoadjuvant chemotherapy. TNBC or HER2 positive disease, if tumor is more than 2 centimeters or not positive, we should offer neoadjuvant chemotherapy. So, if we recap, who are the candidates for neoadjuvant chemotherapy? The rule of 3, tumor T4, any not positive, TNBC or HER2 positive case, tumor should be more than 2 centimeters or not positive disease. So these are the 3 groups that should be offered neoadjuvant chemotherapy. Now come to the point whether all those patients should be offered with neoadjuvant chemotherapy, or there are some contraindications for giving this neoadjuvant chemotherapy. We should rather say not contraindication, but who are not good candidates for neoadjuvant chemotherapy. Again, the rule of 3. Extensive in situ disease, if the patient has extensive in situ disease, if the tumor cannot be delineated properly, non-palpable tumor. These are those groups that they are not a good candidate for neoadjuvant chemotherapy. Now, whether all those neoadjuvant chemotherapy are going to produce equal outcome, or is there any predictive markers that can give us idea before giving neoadjuvant chemotherapy that which groups are going to get good outcome. So this is a good paper. It was published in 2010. Here you can see that the PCR rate is quite high in grade 3. So higher the grade, good pathological complete response rate. If you can see, if the patient is ERPR negative, the PCR rate is high comparative to those who are ERPR positive. So ERPR negative subgroups can get good result with neoadjuvant chemotherapy. And very interestingly, that the triple negative group, the PCR rate is highest. So from these slides, again the rule of 3, triple negative breast cancer, hormone negative, and grade 3 group. These are the groups that are going to get good result with this neoadjuvant chemotherapy. So these are the recap. The TNBC, HER2 positive, and grade 3 groups are going to get good result with this neoadjuvant chemotherapy. So before giving the neoadjuvant chemotherapy, we should keep it in mind, and we can guess which patients are going to get a good result. Not only these things, we should also keep it in mind that the ductal carcinoma are going to get good response rather than the lobular carcinoma. So as there is a favorable group, obviously there is an unfavorable group. So who are those unfortunate groups? This is the mirror reflection. Those who have hormone positive, strongly positive, those proliferation index Ki67 is low and low grade. So the rule of 3, low grade, low Ki66 index, and hormone positive, higher strong positive groups, they are unfavorable for neoadjuvant chemotherapy. So if you are going to give neoadjuvant chemotherapy for these groups, you can get an idea that the response might not be very heroic. So now we can shift to our next discussion. So we are convinced that neoadjuvant chemotherapy is effective. We already get an idea. We have already get an idea who are going to get good benefit from this neoadjuvant chemotherapy and who are not. Now, if we are convinced, then how should I going to treat my patients with this neoadjuvant chemotherapy? With which chemotherapy regime? So there are lots of trials, lots of studies. So this study, NSABP 18, they have tried with AC. This is one of the important trial for this neoadjuvant chemotherapy. So you can see with this doxorubicin cyclophosphamide regime with 4 cycles chemotherapy, they have statistically proved that the neoadjuvant chemotherapy increased the breast conversion rate. And here you can find that the 8% conversion rate, breast conversion rate was 8% higher than the post-op chemotherapy group. But long-term results of B18, NSABP 18, they failed to find any overall survival difference between neoadjuvant and adjuvant group. Not only that, they have raised a very important issues that they have found that ipsilateral breast cancer recurrence rate is quite higher for those with neoadjuvant chemotherapy. So later we will pick up these issues. NSABP long-term results analysis, here you can see that the red marker, red line, those are those patients who achieve pathological complete response rate. And the white line, no clinical response. And partial clinical response is the yellow line. So here with these lines, you can see that those patients achieve pathological complete response rate with neoadjuvant chemotherapy. Ultimately, this disease-free survival rate is quite higher than those with less response. So after doxorubicin cyclophosphamide FEC, here comes the era of taxane. So is there any role of taxane? So is there any advantage role adding taxane with this NSABP 18, that means AC? So in NSABP 27, with this AC, they have tried docetaxel in neoadjuvant setting. And they have found that the docetaxel, adding the docetaxel with AC, it produced around 43. That means double pathological complete response rate. Here you can see with the AC that the complete pathological response rate is around 13%. With the ACR adding Taxel, here in the 25.6%. So the pathological complete response rate is quite doubled with this Taxel. So NACT 27 give us the idea to add docetaxel. So not only for the N2 disease, here you can see they have taken all groups of patients with node negative and node positive disease. And with this group, they have found this good pathological response rate. So some of us have an idea that taxane should be given with only those patients with node positive. In NACT 27, they have showed that even you can give, it is a node negative disease. So regarding the dose, we can get an idea that doxorubicin, cyclophosphamide, and docetaxel or paclitaxel, taxanes can be a good option. Now, is there any role of this giving this scheduling this chemotherapy? So, is there any difference of is there any difference of giving this chemotherapy? So, here in this meta-analysis, with more than 37,000 patients, it is published in Lancet 2019. Yet they found that dose-dense chemotherapy means the dose is quite higher, and you are going to give this chemotherapy with short fraction. Instead of 21 days, you should give it in 14 or 15 days. You can get very good result. Whether it is ER negative or it is ER positive, it can show the rate of recurrence, the breast cancer related date. Dose-dense rate is better than the standard chemotherapy, but toxicity is quite higher. All those patients are treated with prophylactic DCSF. So why not to treat with some biologics? So this is the NOAA trial. They have tried neoadjuvant biologics, that means trastuzumab. And this NOAA trial, they have found that the PCR rate is quite high with addition of these biologics. Here you can see the new Ultra trial. It is also published in 2012. They have tried dual HER2 targeted therapy, trastuzumab, lapatinib, and they have given a window period only for the biologics. And they found that the dual HER2 blockade treatment ultimately produced better outcome, particularly for those patients with HER2 positive disease. Here comes this new SPAD trial. They have showed that adding trastuzumab with pertuzumab with docetaxel, the pathological complete response is significantly higher. So these are the main trials that have shown that the biologics have a very good role to achieve this PCR rate, a commendable PCR rate. So here you can see this is the sum up, the dual HER2 blockade, only dual HER2 blockade, you can achieve 29%. So there might be some groups who can be avoided with chemotherapy. Dual HER2 blockade with taxane, 62%, taxane plus other agent, 80%. So combination permutation is going on to achieve a good pathological complete response rate. So sitting in the era of 2020 without a word regarding immunotherapy, it's not possible. So here comes the immunotherapy. In early stage triple negative breast cancer, in this keynote 522, they have tried pembrolizumab in triple negative breast cancer, and they have found a significant pathological response rate, that is adding trastuzumab 64% compared to 51%. So they have found a very good result with adding this trastuzumab, in particularly for TNBC. So last of my presentation, this is a very latest publication published in May 2019 in this year, and this is a meta-analysis, more than 27,000 patients, and they have tried different aspects, and they found that the pathological complete response rate is the strongest marker to achieve overall survival rate. So giving this neoadjuvant chemotherapy ultimately going to produce good pathological complete response rate. So the objective of our treatment should be focused on to escalate or escalate or adding or subtracting some agents to achieve a good pathological response rate. So by adding this group of drugs which can produce good pathological response rate, we can ultimately produce good overall survival. So neoadjuvant therapy ultimately can produce, if can produce good pathological response rate, it can produce a good overall survival rate. So the take-home message: neoadjuvant chemotherapy with targeted therapy can be practiced to all indicated patients. Pathological complete response rate is the strong surrogate marker for survival. It offers, if it produces pathological response rate, it can offer both overall survival and event-free survival rate. And immunotherapy, promising result for TNBC, and we should not forget for MDT for all. Thank you.
So thank you, Sumon, for your presentation. Now we will move to the question answer, but I will ask our foreign faculty whether they would love to make the comment now or they want to make the comment at a later stage. Zakir Bhai or Farid, what do you think?
আমার মনে হয় আমরা একটু পরেই করি carry on.
Okay, so may I ask the juniors? I mean, junior means below assistant professor, either post graduation or students, to volunteer their questions. I don't know how many of them has written the questions. You have still the time to put it in the chat box, or you can unmute yourself and identify yourself and ask the question. And answer may be answered by Sumon or maybe some others. So we can stop the screen share. And if Masum is ready, in the meantime, when the people are getting ready for the question, you can make the presentation of the last.
Okay, thank you, sir. You can please make the screen share option available for me. Okay, now it's working now.
Oh, sir, you can share your screen.
Okay. Is it working now?
Yep.
Okay, thank you. So basically, I am doing the statistical part. How should I treat my practice following evidence-based medicine? This is the title of this virtual academic program, which is organized by Oncology Club. So this is the third session. In fact, in our first session, second session, the title was non-invasive breast cancer, which was conducted by Dr. Asma Siddiqa, Assistant Professor of Radiation Oncology, NICRH. Dr. Mohammad Zakirullah sir and Dr. S.K. Fodis sir was overseas faculties for that session. And there are some review of our second session. For the second session, we invited 62 guests, and among them 58 doctors were participated, and 16 participants participated in quiz section. And we got feedback from 10 participants. So it is a graphical presentation of this invitation, participation, quiz, and feedback. And there is winner of the session 2, Dr. Tania Haq. She was from Department of Radiation Oncology, National Institute of Cancer Research and Hospital. And this is the comparison between our two sessions. We have only two sessions, and that is in every aspect, from invitation, participation, quiz, and feedback, we are getting better day by day. So that's from my part. Thank you.
Thank you, Masum. So Regan, we stop the screen share. So till now, I have seen only one question in the chat box. It is A.B. Mannan. So may I ask Mr. A.B. Mannan to ask your question? Mr. A.B. Mannan. Dr. A.B. Mannan, please unmute yourself and ask the question. And first identify yourself.
I am a postgraduate student. Currently, I am in the phase B, and I have passed the clinical examination. My thesis is delayed due to pandemic situation. Well, I have a question in the Mostafa Aziz Sumon sir. So, if a patient gets the neoadjuvant chemotherapy and later I want to do the breast conjugate surgery with that patient, so what will be the marginal status of this patient? Previously said that R0 resection margin, and how will I decide this R0 resection margin? And how will I evaluate the response of this patient?
So your question is how you are going to define this R0 resection, right?
Yes. And how will I evaluate the actually response, the neoadjuvant chemotherapy response, how will I evaluate this response rate?
Okay, so you can evaluate this patient in two ways. Number one, clinical response, that by palpable this lesion by palpate or by radiologically, you can go with ultrasonogram. So if the initial size was like 5 or 6 centimeter, so with this radiology, you can get an idea how much your tumor has shrank. And obviously, with pathological histopathological reports post-operative, if there is no malignancy is there, you can say it as a pathological response rate. So either clinically or pathologically, you have to classify this response.
So I think Farid, would you like to make some comment on it? Yeah, please. You can unmute. You need to unmute yourself.
Okay. So during the NACT period, the clinical assessment is the main part. The radiological, the imaging is not recommended. So if there is any idea that this patient is having progression of disease, that time you have to do the imaging and then promptly you go for surgery if the patient is operable. And but during the period of chemotherapy, no imaging is recommended. And after the whole completion of the whole chemotherapy, if you want to do a BCT, that time MRI is indicated to evaluate the extension of the disease.
Can I ask a question?
Well, I have another issue that
Hello?
R0 resection margin. How will I define the R0 resection margin?
I think for surgeon should answer. Farid. Farid, yeah.
Okay.
Farid, please.
Thank you. First of all, after neoadjuvant chemo, you could do a clinical examination or by images. And what we practice in the UK is we usually like to get an MRI or at least an ultrasound scan to see response. And based on the response, both on clinical and image findings, you decide what type of surgery you do. Assuming there is a good response and patient is suitable for breast conserving surgery. Obviously, you do wide local excision, the margin has to be at least 1 millimeter clear margin, all rounded, then surgical treatment is complete. So it could be 2 millimeter in different places. What we practice in UK is 1 millimeter. So therefore, specimen orientation is absolutely key. And one thing I have to say, suppose if cancer was 5 centimeter, and now post neoadjuvant chemo, the response clinically looks like a 1 centimeter cancer. If you do not have to excise 5 centimeter, the original tumor bed, there is no evidence or any paper that would suggest that you have to excise the original tumor bed. You'd be guided by what you could see after neoadjuvant chemo, the size of the cancer on clinical and images. So we do practice imaging after to evaluate the response. Does it answer your query?
The full cycle of chemotherapy, not in between. Okay.
Can I add?
Well,
yeah,
I agree with. Can I add?
Yeah, please, Zakir Bhai, go ahead.
Yeah, I completely agree with Farid. The protocol here normally we do at the start of the treatment, we do an MRI. Okay, the reason for doing MRI scan to have the primary assessment of the tumor. Say, for example, if somebody has got 6-7 centimeter tumor, very unlikely, even if we have got a good response, we probably have decided that this patient will get mastectomy. That is a preliminary approach, that if there is good response, then we'll consider again. But very likely, 7 centimeter tumor in a small breast, I mean, we decide that irrespective of response, we'll probably go for mastectomy later on. Forget about that scenario. If I'm saying that halfway through of the chemotherapy, we do another MRI scan to assess the response of the first 3-4 cycles. And then after that, at the end of the treatment, we do another MRI scan. That's how we normally assess the whole tumor response radiologically. Clinically, of course, that is important as well. Clinically, we need to see whether this is shrinking or not, but that has very little value in the field of complete radiological response. Okay, I agree with Farid that if another part of neoadjuvant chemotherapy is to treat the tumor, so that some non-manageable. I mean, if we want to do a breast-conserving surgery, then this is possible. But you have to be very realistic from the very start. As I said, if it is very big tumor, we can't do anything. But of course, we can see the complete pathological response later on. But if it is a small tumor, so 3 to 4 centimeter or even 5 centimeter, shrunk to 1 centimeter, if you remove exactly same way I'm saying that 1 millimeter clear margin has to be there. If it is not clear 1 millimeter, you have to go back and excise more tissue out. Does it make sense?
Yeah, okay, Zakir Bhai, I get your answer. I think Farid want to add something.
Thank you. I would be I entirely agree with Jacobo's comment, except I would be slightly cautious about some pre-setting in your ideas that, well, this is a 7 centimeter cancer and it's a big breast. Whatever the response is, even if it's a complete clinical response and complete radiological response, I'm going to do a mastectomy. I would be slightly cautious about it. I don't think that would be a standard practice in other units or all the other units in UK. So you'd be eventually guided by what you see after the response, because one of the goals for neoadjuvant chemo is downstaging and to reduce the distant recurrence and also to see prognosis. And by doing a breast conserving surgery, if you're able to achieve 1 millimeter clear margin, it should be fine. So I would be a little bit cautious about having a pre-setting ideas about the original size of the cancer pre-neoadjuvant chemo, and your mindset what operation you're going to do irrespective of the response, because that doesn't really match with the true essence of the neoadjuvant chemo goal. And other question is, if you have a set idea that it's a 7 centimeter cancer or 8 centimeter cancer, a different breast volume, where is the standard that you decide pre-neoadjuvant chemo that this patient is going to need a mastectomy? There isn't any. So I'll be slightly cautious about it. I hope Dr. Labai can respond.
Can I challenge this one?
Yeah, please. Yeah, please.
Okay. The problem is we all think that the neoadjuvant chemotherapy is killing cancers from periphery to center. It's wrong. Some of the cancers can have fatty necrosis at the center area. Sometimes some of the cancers can respond peripherally. So if somebody has got 7 centimeter cancer, I especially mentioned 7 centimeter VCAP, definitely if we always take a plan, even with the neoadjuvant chemotherapy, because neoadjuvant chemotherapy is not 100% foolproof. Even with that complete radiological response, we have seen some pathological response is not there. So still this is a very new field. I think we always do, and most of the centers in the United Kingdom are actually pre-assessed what would be the real treatment, unless we find nothing there. So that's a different thing. But most of the times we decide if it is a mastectomy, it's a mastectomy irrespective of neoadjuvant chemotherapy. We'll do mastectomy and then see the real response. Because don't get fooled by thinking that neoadjuvant chemotherapy can only response from periphery to center. It never happens like that. John can put some points here. John,
would you like to make some comment here? John.
So we will make upfront decisions. So multicentric breast cancer, I'm sure Zach will agree, and that if you've got multicentric breast tumors as well, we will make an upfront decision to do mastectomy for selected patients, irrespective of neoadjuvant treatment. So whatever response they have, they'll go on to have their auxiliary surgery and mastectomy, for instance. So
I think what I'm going
John,
to do.
The question was about not a multicentric cancer. The question was about a single cancer.
Yes. It's quite big, actually. That's what I'm saying. That we should not be very much reliant on the neoadjuvant chemotherapy. Still, we haven't actually got the whole results. It's a thinking process now. I know that probably what percentage of patients actually getting 30-40% getting complete pathological response? Not 100%. I'm sure you agree with that. John, what do you think? What percentage of patients actually from the study of neoadjuvant chemotherapy is getting complete pathological response? Pathological, not radiological.
So we get good rates of path-CR. We're seeing better and better rates as well as we add in additional therapeutic drug combinations. You touched on the addition of immunotherapy, and there's more drugs being added on in clinical trials all the time. Going back to the size, though, there are some patients who that we will make a decision. So large T3 tumor in a very small-breasted lady, you know, even with a very good response to neoadjuvant chemotherapy, there is often a discussion with the patient about mastectomy up front, you know. So, but you're right, it's a dynamic process, and having imaging pre-treatment and post-treatment can influence those decisions. So it's not a one-size-fits-all scenario.
Okay. What I understand that as John concluded, it is not one size fit all. So we are going to have one session on breast conservation surgery, where we will have some more discussion in details about the pros and cons of doing the conservation and mastectomy after neoadjuvant. But the message is very clear. We are getting a huge pathological response, which is translating to survival. Whether we do a breast conservation and mastectomy, that is a different debate. But definitely today, if we can conserve a breast, definitely we will. But we will never conserve a breast where we are thinking that is risky. So it is the perception of the patient, surgeon, MDT decision. It is not a rule of thumb that must be breast conservation. It is not a rule of thumb that it will be a mastectomy. The thing is that what is best for the patient, but whether it is a mastectomy or conservation, the biggest news is NACT is giving us a big survival benefit, I mean, in form of PCR. So that was the thing. So we had some few questions more, and I wish this question answer session might be put longer, but you know, we want to keep it on time. So there was one more question that whether role of endocrine therapy as neoadjuvant from Dr. Irshadul Haq. So we didn't, today what I'm going to tell that I wish I discuss it today, but I'm not discussing because I designed a session that will be total role of hormone therapy on breast cancer. Because if we keep on moving from one track to another, I think we will be wasting some time. So that's why, and I see some more other questions we are covered in my case regarding the number of cycles and how to assess, and some of the answers already covered. So I see Farid again raised his hand, maybe want to make some comment. Quick comment, Farid.
I'm sorry. I think it would have been worth if you could have kept a little section on neoadjuvant hormone therapy, especially corona pandemic situation.
Yeah, we will.
Great opportunity, especially in corona pandemic situation.
We will.
If you have positive cancer, you could treat them with a neoadjuvant hormone therapy and wait till the pandemic is over. So that could have been an opportunity we could have used today. Thank you.
Thank you very much. So we are very soon we will have a whole session, not only neoadjuvant, on a whole role of hormone therapy where neoadjuvant will be covered. So I see the friend. Yeah, please, Nafisa.
My question towards Dr. Sumon, before starting neoadjuvant chemotherapy, you put any marker clip at the center of the tumor, you suggest or not? Because after 3 or 4 chemo, when the patient came to us, it is definitely become non-palpable, and at my experience, 2 or 3 patients become 1 centimeter by ultrasonography, not by MRI. So do you think that something had to put at the neoadjuvant before the neoadjuvant chemotherapy started, Dr. Sumon, to add?
Okay, Nafisa, I am taking the question. I am taking the question on behalf of Sumon. Just now, I'm not going to answer you. This point will be discussed in our case discussion. We have designed that everything is not in the presentation. Some is in the case discussion. So very important issue. We will bring it in the case discussion. Shahida Alam.
Yeah. So first of all, I want to add a very important thing about our today's presentation, which was missed by Dr. Kamal. He's the only frontline COVID fighter from our oncology community. He has been served as a first-line COVID fighter in a COVID hospital.
Absolutely.
And we are not. So for this, all our blessings and our dua is with him. Okay? This is very important. He is our, I think, pride and honor, I think.
Yeah. Thank you.
And I have a question regarding NACT regimen. So to Dr. Sumon, do you think it is different from the regimen which we use in the adjuvant setting? The neoadjuvant setting and adjuvant setting, the regimens are different? It should be different?
Sumon.
Sumon?
Are you there, Sumon?
Sumon, are you there?
Huh? Disconnected?
Disconnected.
Okay, so anybody want to volunteer this answer? Sumon is somehow he's disconnected. Anybody want to volunteer this answer from our local faculty? If not, then I will ask John. But I am not going to answer, even I have an answer, but I want to have some local faculty. I see many other faces like Arman Reza, Runanshu. I see Rokon.
Because Sumon showed some protocols for new adjuvant.
Yeah, yeah.
So my question is different for new adjuvant.
No. There is scientific answer for that, Shahida.
Yeah.
But anybody from local want to answer this? Anybody volunteer? Runanshu? Rokon? Okay, so I go to John. Could you please answer? The question is whether they should select the same thing that will be selected for the adjuvant, for the neoadjuvant, or they should be changing the
It should be different. Yeah.
Yeah, John.
Yeah, so there are some nuanced differences for neoadjuvant and adjuvant protocols. Broadly speaking, though, neoadjuvant and adjuvant are very similar. So for estrogen receptor positive, HER2 negative breast tumors, they're both really the same. Probably the biggest difference is triple negative breast cancers. So the use of combination immunotherapy, chemotherapy is really only in the neoadjuvant setting. We're not using it in the adjuvant setting. And you probably also know that the CREATE-X study was looking at adjuvant capecitabine in triple negative breast cancers. It benefited most those who had residual disease post neoadjuvant chemotherapy. So there are some minor differences, I would say, in what you select and when. So it is important to bear that in mind.
Thank you, John. What I understand, Shahida, in general, you should select the same thing, but in some instances, as John said, if you are thinking something different, then maybe you can think of something different. But normally the rule of thumb is consider the same drug that you select for adjuvant that should come to the neoadjuvant. Yeah. So I think we had a wonderful question answer session going on.
I have another question.
Yeah, please.
I have another question. Okay.
Yeah.
And another important thing is to add that if you initiate the neoadjuvant chemotherapy, you should complete the full cycle before surgery. This is a new concept which we didn't practice previously, or you did sandwich.
We will be covering that.
Yeah, that. Okay. And Sumon is not available here.
Yeah, no. So I will answer on his behalf.
Who's going to answer this question? Who is going to answer this question?
Which one?
My second question. So would you offer NACT to a HER2 positive early stage breast cancer patient when you have the assumption that this patient is not going to have trastuzumab, or she cannot afford TDM1 afterwards? So for this patient, you will offer NACT or not? The patient will not afford trastuzumab.
So your question is, if I'm not wrong, that it is early stage breast cancer. She is a candidate for NACT, HER2 positive, but she cannot afford trastuzumab. In this condition, shall I give her NACT without trastuzumab? That is your question.
Without trastuzumab. Yeah.
Okay, so anybody locally want to volunteer? I prefer some new faces. I see Dr. Asma, I see Colonel Rukon, Lieutenant Colonel Rukon, I see Taposh Mitra from Chittagong, I see many faces. I'm so happy to see 65 participation, but nobody is talking. Can anybody volunteer to answer? Anybody? Arman is having a problem. He cannot talk, so he is writing the answer always, but anybody want to talk?
Or Dr. John can answer.
So, John, somebody is a NACT candidate with HER2 positive, but she cannot buy HER2. Sorry, trastuzumab. So, shall I give her NACT? It is an early stage.
Early stage HER2 positive.
Early stage. HER2 positive, but unfortunately she cannot afford. Now there will be some question, I'm sure, asking, John will ask, what is the hormone receptor status and what is the tumor size?
Without hormone receptor status, positive or negative?
Okay, John. She wants to make your life difficult. Answer to her.
Tumor,
so I would.
2 centimeter and more, node N1 and more.
Okay.
So you know, if you've only got you could only offer chemotherapy. So first thing is I'd look to see whether there's the opportunity to get hold of some biosimilar trastuzumab, as it's much cheaper. Yeah,
not at all.
So, but no, if you only have access to chemo, then I would offer her neoadjuvant chemotherapy without trastuzumab, as it's probably going to offer her more survival benefit than not giving any chemotherapy alone, you know. Of course, bearing in mind her stage of disease. So if she was a candidate over 2 centimeters, node positive, then giving her anthracycline taxane-based chemo without Herceptin still will offer her more of a...
So would it make difference, this chemo I give adjuvant? Because if I don't use the immunotherapy, trastuzumab, there is no meaning of giving neoadjuvant chemotherapy for an early stage HER2-positive breast cancer. Because in this case, the complete response rate is about 31%. And if I add trastuzumab, that transforms to 50%. So trastuzumab is the main guiding force here. So if I can't use trastuzumab, so why should I use only chemotherapy?
Because you're still adding a benefit of survival advantage to her, aren't you? Yes? So you will increase it with trastuzumab.
I can use the adjuvant.
But so giving it adjuvant or neoadjuvant, what you're still gaining by giving it neoadjuvantly is you're seeing the chemo sensitivity of her disease, and seeing a 30%, if you did see a path CR, even with the chemotherapy, it's more reassuring that she may have that translates into long-term disease-free survival. Whereas if you give it adjuvantly, then you'll never know her tumor biology in regards to chemosensitivity. But I would also say, though, that I wouldn't risk surgical inoperability. So if she was on the borders of surgical operability when she presents, I probably wouldn't take the risk of giving her neoadjuvant chemotherapy, because if she didn't respond and had progression and became inoperable, for instance, then I wouldn't take that risk. Yeah.
Okay, John, I am with you. Even it is she cannot buy trastuzumab. I want to give the benefit of doubt of the the sensitiveness, the responsiveness of the chemotherapy. But it is I know Shahida is nodding her head, but it is your personal choice. But the recommendation is when there is a node positive, when there is a node positive,
this time the condition is even worse.
Okay, no, when there is a node positive, even it is a ER positive or negative, you should challenge it with the chemotherapy as an adjuvant. But there is no harm to avoid it. But we should think that there are some data in favor. So the last question and comment I'm going to take from Farid, I want to switch to our case discussion because we want to finish it by 1.5 hours. So Farid, then I will share the screen.
Thank you. Please correct me if I heard it wrong. Right. Neoadjuvant chemo has got a survival benefit over adjuvant chemo, because my understanding is there isn't. Although chemotherapy improves survival, but neoadjuvant chemo versus adjuvant chemo, there is no difference of survival. That was my knowledge.
No difference. Yeah. No difference.
That is correct. Lima is correct. There is no difference. So I heard it from John, so I got confused.
No, it is John was telling that by giving the sensitivity, chemosensitivity, and if you are getting a PET CR, which is not possible from adjuvant chemo, so he wants to take that chance, that still you have a chance of achieving around 30% PET CR, which will offer her a survival benefit. And when we are using it adjuvant, if for any reason these drugs are not working, so we will be giving her blind treatment, and it is a node positive. So John is in favor of that. So that was the comment.
Drug will work. The drug will work. Whether you give adjuvant or neoadjuvant, the drug will work with the tumor cells. But pathological responses is not always.
Can I add?
Yeah,
please. Add. Plus, I completely agree that whether it's neoadjuvant or adjuvant chemotherapy, the effect is not the same. But the good thing about neoadjuvant, what we actually noticed, that if the tumor already there, you start your chemotherapy, and if you see a good response with that chemotherapy, then you're confident that this will work as adjuvant as well. If not, you can change, even in the neoadjuvant setting, then if you add something else. That
was the thing. Okay,
so you can change the treatment.
Okay,
Yeah.
Lima, I think we stop it here because this discussion is a never-ending story. So now I need a volunteer, somebody who wants to be the volunteer for the case discussion. Anybody?
Yes, sir. Dr. Altaf Hussain and Dr.
Altaf
Shruti.
Hussain. Okay, Dr. Altaf Hussain, are you with me? Please unmute yourself.
Yes, sir.
Okay, so you are in the hot seat today. So it is a case, a 30 years old premenopausal lady with known comorbidity. She has a right breast lump measuring about 5 by 5 centimeter, clinically palpable lymph node, which is 3 centimeter in size. Ultrasonogram of the breast shows the suspicious right breast lesion. Mammogram was done, and the BIDEX 3. Core biopsy of the lesion revealed it is infiltrating ductal carcinoma, grade 3, ERPR negative, HER2 positive, Ki67 30%. FNAC from the axillary node was done, and it was positive for malignancy. All other laboratory parameters were normal. CT scan of abdomen chest was done, no sign of metastasis. So clinically, the patient is CT2N1M0, right infiltrating ductal carcinoma. So now, what will be your plan of treatment? I am giving you some option. NACT followed by surgery, followed by adjuvant chemotherapy, plus targeted therapy, then radiotherapy, or you want to do a surgery upfront, give adjuvant chemotherapy plus targeted therapy, then radiotherapy, or you want to give NACT plus targeted therapy, then surgery, then radiotherapy, or you want to give NACT plus immunotherapy, then surgery plus radiotherapy. What will be your option?
Sir, I want to go with option 3.
Option 3, you want to give NACT plus targeted therapy, so with surgery. Very good. So we see.
First slide again, please, sir.
Sorry?
First slide again.
We shall appreciate that. Please be focused. We cannot do it second time. This is for the last time because we don't have much time to spare.
Okay,
we have a long list. Okay. So now he has gone for option 3. Now let's see what is the. This was the slide already Sumon showed that what are the factors that we consider grade 3 receptor negativity and triple negativity is the main beneficial from neoadjuvant chemotherapy. And as per this ESMO publication, who are the best candidates? They say that age less than 40 years, ductal histology grade 3, Ki67 more than 14, TNBC, receptor negativity, HER2 positivity are the better candidates to achieve PCR. So in this case, what points we have? The lady is less than 40 years, size it is a node positive, it is a ductal carcinoma, grade is 3, ERPR negative, and HER2 positive. So, and Ki67 is more than 14%. So MDT decided to give NACT followed by surgery and RT. So now, to you are with me,
yes,
my
sir.
Today's consultant. Yes. So what protocol will you take for the neoadjuvant chemotherapy? FAC, acitaxane, TC, acitaxane plus trastuzumab.
Last one, acitaxane plus trastuzumab.
Wonderful. We will take acitaxane, we will trastuzumab.
And dose dense.
Okay, great. So acitaxane, trastuzumab, and pertuzumab. I had another option.
Yeah.
So would you like to change your decision?
Yes, sir. I want to change, sir.
Which one?
Acitaxane followed by trastuzumab and pertuzumab.
Okay, wonderful. So the tumor board recommended acitaxane 8 cycle plus trastuzumab and pertuzumab as neoadjuvant chemotherapy. So the question is, why not acitaxane as a sandwich technique? Why to finish it earlier? Consultant, would you like to answer to my question?
Sir, I can't.
So why not 4 cycle before and 4 cycle after? Why you want to give all before? This was a question already raised by some of my colleagues, which I kept that we will be discussing now. Do you have any answer?
So maybe
no,
pathological complete response will be better in completing the whole regimen.
Wonderful. But now we will be trying to answer with some evidence. But yes, you are 100% correct. With the time, you see the model change. This car becomes this BMW. So the practice also changed that once we used to love the sandwich, now we love pizza. Because in sandwich, you have bread on the two sides. Now we have one side pizza, or bread, and one side is the food. So this NACT 27, it had shown that when you are giving pre-op AC alone and we are putting taxane, they are achieving higher percentage of FCR, wind and clinical CR by adding the taxane in pre-op setting. And Sumon has shown that it is applicable for all the groups. And in this publication of 2019 of ESMO, they have said very clearly that all chemotherapy should be provided before surgery, not split into pre and post-operative. So this is a message that we should be carrying, that if we are practicing chemotherapy neoadjuvant, we should try to finish it all before upfront, not to keep for sandwich. No more sandwich, let us move to pizza. So would you like to continue or you want to give it to somebody else?
Yes, sir, I want to continue. No problem.
Okay. So will you prefer to give trastuzumab as neoadjuvant or as adjuvant? So because she said, I don't have money, I want arranging some money, I want to give it later. Doctor, you finish my chemo 8 cycle. Would you agree with her? If not, give your logic. If yes, give your logic.
If it is possible, if patient can afford, it should be used trastuzumab as neoadjuvant, because if there is no pathological complete response, if no pathological complete response, then we have to add DM1.
Okay,
in
so
adjuvant setting.
You are in favor of using trastuzumab as neoadjuvant.
Neoadjuvant.
So let us see what the data says. HER2 positivity is a poor prognostic type of the cancer. You see, on the survival, this is almost at the bottom when a patient is having a HER2 positivity. So it is not a good news, it is a bad news. But in NOAA trial, they have shown that when you are adding that neoadjuvant trastuzumab to HER2 positivity, it is giving a better survival compared to chemotherapy alone in neoadjuvant setup. So NOAA is a evidence in favor of you bringing trastuzumab before in neoadjuvant setup rather than putting it into adjuvant. So when you tell your patient, you should give her the reference of NOAA trial. So why not only trastuzumab? It is costly. So patient said, sir, I want to give only trastuzumab. I don't have money. I cannot give pertuzumab. Will you agree with her?
Sir, as earlier, Sumon sir showed us that in NewSphere trial showed adding of both trastuzumab, pertuzumab with docetaxel is giving us more pathological complete response.
Wonderful. You remember Sumon said, and that is the true thing, that in NewSphere trial, they have shown that all the 4 arms, and among all the 4 arms, when trastuzumab and docetaxel, best performance when you are putting dual blockade. So highest clinical pathological response is achieved by dual blockade. So if possible, we shall tell her that, lady, if you can, we want to bring both the pertuzumab, trastuzumab, and all chemotherapy prior to the treatment in neoadjuvant. So can we have our second consultant? I think wonderful. Congratulations. You have done a great job. You have done 99% correct of all the questions. I really appreciate it. Even I didn't have all the answers before I prepared it. So can I have the next consultant? Who is the next consultant?
Dr. Shupti.
Dr. Shupti, are you there? Please unmute yourself.
Kamal bhai, breast cancer পড়ায় কে ক্যান্সার ইনস্টিটিউট আগে একটু জিজ্ঞাসা করে।
Okay, I know it is Dr. Shahida. So, Dr. Shupti, are you there?
I want to inform that I am the trainee of Dr. Shahida Alam, sir.
Thank you. So, congratulations to Shahida.
Thank you,
Dr.
sir.
Shupti, are you there?
Yes, sir. Assalamu alaikum, sir.
Wa alaikum assalam. Shupti. So, we are continuing. You see that the NewSphere trial was there, but when we look at the 5-year analysis of this, you can see that still the group B, that is the dual blockade with chemotherapy, is doing better, and both in progression-free survival and disease-free survival. So let us look at the patient now very carefully. After first cycle, the patient's lesion is this, second cycle this, the fourth cycle is this, and the axillary node is gone. In 6th cycle, what I missed here, it is AC, and then here we have added the trastuzumab and pertuzumab. Let us create a scenario like that. But the scenario is at one situation, everything is gone. So how to make further assessment? And this situation, ultrasonogram is sorry. Ultrasonogram is done, and ultrasonogram is telling that we cannot see anything, neither in axilla nor in the breast. What will you do, Dr. Shupti? Dr. Shupti, do you want to do something? You have done the examination. Even Dr. Shahida has done the examination. She cannot find anything. Sonologist said, sorry, nothing is there, neither in the axilla nor in the breast. What you are going to do? Okay. So this is MRI. So breast MRI is a good indication. Who is asking the question?
Sir.
Not question. I have a query.
Hello.
Lima, let us not stop here.
Why did you do ultrasonography?
It is not why did we do. It was my patient. I was doing like that. I didn't knew that I didn't have an MRI or something. So at this stage, I came here and I was stuck up. And now I am thinking, what should I have done? The recommendation is the breast MRI is a good tool that should be done in this type of situation before treatment and to see the response. That is the standard recommendation that already we had some discussion and hopefully we'll be discussing more. But the message is here that yes, this is a tool that we can use. Another thing is sequential biopsy. This is not a routine practice, but this is also mentioned that we can do integral biopsy sometimes to do, but it may not be a very encouraging thing. So MRI base showed no residual breast cancer, but only single node, smaller in size. Dr. Shutpi, what will be the recommended surgery? You will tell. What do you think that surgeon will do what at this situation? No tumor in MRI, ultrasonogram, palpation of a very small axillary node. What will you do?
Sir, wire-guided wide look.
Now you cannot, there is no, what you are going to do excision? There is nothing.
Can I
at this moment, patient came now to you.
I'm Nafisa. Can I add?
No, Nafisa, I am asking my consultant. You are not my consultant now. I am asking my consultant. Dr. Shupti, what do you like to do?
Sir, breast conserving surgery.
Unfortunately, you cannot because you don't know where is the tumor. You didn't locate it.
Sir, wire-guided wide local excision.
Where?
Sorry,
we have never put a marker. Somebody didn't do it. They have done the treatment and now patient came to you after finishing the treatment. That nothing is there. So how can you do it? Even Farid cannot do. Jakirullah Bhai say, sorry, I cannot because I cannot see the tumor. So the only option here is mastectomy. Mastectomy with axillary dissection. So the next question to you is that, so which one you want to do? Mastectomy, only axillary dissection, or mastectomy with axillary dissection? In this patient, there is no marker, but there is a small node. There was a tumor in the breast, but now we cannot see it. What will you do? 1, 2, or 3. Which option? Shupti?
Mastectomy with axillary dissection.
Thank you. I agree with you. The tumor board recommended to do a mastectomy with axillary dissection. And then my next question is, could we avoid this situation? If the patient was with you from the beginning, what could have been done to avoid this mastectomy?
Yes, sir. Yes, sir.
Yes, tell me, Shupti, what would you like to do? If the patient was with
sir,
you.
Hydromark.
Yes.
Sir, hydromark.
Hydromark, yes. So thanks to Nafisa and Dr. Farid for allowing me to use their picture. This is hydrogel marker implant. If we do it at the beginning, so that even there is a complete radiological clinical response, even we know where was the tumor, and then we can avoid mastectomy, and then we can avoid we can go for breast conservation if we are convinced. So now the question is, if this patient was with you, acetaxane, will you give 2 weekly or 3 weekly protocol, USB 2 or USB 3? Which one will you choose? She is a young lady, 38, totally fit, peacock one. 2
So
weekly.
3 weeks.
You will go for 3 weekly, not
Yes,
2
sir.
weekly.
So 3
Okay,
weeks.
3 weeks. But you see the adjuvant setup, there are obvious evidence that the dose-dense protocol do better, around 15% better survival than conventional if the patient can. But a new adjuvant, there is conflicting results. Some data say positive, some say not that much significant. But this graph curve was shown by Sumon, that these meta-analyses have shown that every sector, in every group, dose density is giving a benefit. So we are extrapolating this data. Now we are trying to recommend dose density even in neoadjuvant setup. So now, do you have any tool to predict the outcome of the NACT? NACT is done. Now the patient asks that how can I see that what is the result of this NACT?
Yes, sir. UK protocol. Sir, predict tool. UK protocol. Anujay.
Predict.
Yes,
Predict can predict some outcome pathologically. Can you do something after doing the NACT is done with the pathology report? It is not 100% pathological response. There is some remaining. So with that, can you tell that what is the? Can you scientifically prove? Okay, let me help you. Residual cancer burden is an interesting thing that they have shown that this is very much helpful in stage 2 and stage 3, not in stage 1. And different type of residual cancer burden gives us some clue. And you see that this group 1, PCR is the best, but in residual cancer burden group 1, do the best. And it is very much available online. With the pathology record, we put it all this information and it will put you that which group your patient will fall in, RCB1, RCB2, RCB3. That will give you an idea about the prognosis. So last question. Can NACT, neoadjuvant chemotherapy, offer any survival benefit?
No.
No. Okay. This was discussed by Sumon, that this is a publication of clinical cancer research in 2020. Before that, everybody was telling that indirectly we can translate path with complete response to survival, but directly there was no evidence. But this is the first meta-analysis which they have shown that there is a survival benefit related to path PCR. And this meta-analysis have shown that overall and event-free survival both is achieved by giving neoadjuvant chemotherapy. And it was a study of 27,895 patients, and they have concluded that NACT offers significant event-free survival and overall survival benefit. And they have shown that adjuvant therapy after PCR does not give any additional survival benefit. So de-escalating is an issue now, that after PET-CR, shall we give chemo or not, that, or any treatment. So thank you very much. Shukti, wonderful. You have done 100 out of 100. Congratulations. So now, Regan, we go to quiz. Please send the link of quiz to everybody. So the moment we start, it will be 5 minutes, 10 MCQ question. Regan, quiz. It is quiz time. Regan.
Links given in the chat box.
Link is given to the chat box, and please log in and we will start counting the time. Regan, start counting the time, 5 minutes. Okay, started. 10 question, 5 minutes, 5,000 Taka cash. Both the previous winner already received the money, so no pending.
Can I come in while they are
please.
answering? I was missing one trial. It wasn't mentioned, trifenol trial, where there was a talk about platinum-based chemo with dual blockade. And you know that NICE guidelines does confirm that triple-negative cancer patients should be benefiting from platinum-based chemotherapy. And the NewsPair, well, trifenol does confirm that 66.2% PCR if carboplatin with dual blockade is given.
True.
I just missed that part because there are a lot of nice trials we mentioned, but this wasn't.
We didn't mention it for it. The problem is number one, time. Number two, what I want here to give some instigation to my junior colleagues so they start looking into it. We cannot cover, breast is a huge thing, even only.
I know.
I mean, so yeah, thank you for mentioning it. It was for TNBC, yes, platinum with, this is one. And what you said, the 6, now it gone up to 80% PET CR is now achievable. So it is becoming a game changer.
Yeah. That was my other question. Which trial does show that 80%? Because to my knowledge, there are lots of trials. The highest I've seen is 66.4%, 2%. That was Trifena with various permutation combination. But I wanted to find out 80% PCR on which trial and which medicine.
John, can you
share
please?
It later on.
Yeah, okay. Okay, so we have 3 minutes more to go. And once you finish the answering, you click on view score, then you will see your own score, and people ask what are the correct answer, you will see what are the correct answer. So after you finish your answering, you can click on view score on the bottom of your screen. So 2.5 minutes more. So today we are trying to be on time. We don't want to, cross the time limit. Maybe we'll be crossing for very small, but still we are trying not to be on 2 hours. Take some preparation. Somebody want to be the volunteer for the rapid fire. 10 question, 20 seconds time. 2 seconds for each question. Okay, I see some name, volunteer. Some others name also. Yeah, recording will be shared. Recording will be sent. Almost only 1 minute more. I think 5 minutes is too much. We should make it 3 minutes. 5 minutes seems to be very lengthy.
Sir, this is Dr. Kollol. Can I ask a question, sir?
Yeah, please, Kollol, go ahead.
Sir, regarding pathological complete response. So, to know that, if you have to excise the tumor first, right, and send it to histopathology. So, if you if you are asking about the residual tumor scoring or something like that, so without doing the surgery, how can I confirm the?
No, that is after surgery. That is on the pathological report. That is on the pathological report. That residual tumor burden is on pathological report. It is not before surgery.
Okay, I'm clear. Thank you.
Alright, can I share an interesting trial?
Yes, please.
USA multi-center trial is ongoing. Mayo Clinic, MD Anderson, and quite a few other ones. And what they're doing, neoadjuvant chemo.
Commit surgery.
And then if there is a good clinical and radiological response, they just carry on doing 6 monthly core biopsy on that marked area, like where the marker key was inserted. And if there is continue to show complete response, they just carry on following it up. And this is very interesting.
I didn't bring that. I went through the trial. I went through the trial. I didn't bring it because it's quite still controversial. But yes, they are trying to
controversial at the moment. Yes, I agree.
So that's why I didn't train. Yeah, that is a thing going on. Okay, now we will take some time to move to for the compilation of the result. In the meantime, we again go to the rapid fire session. So in the rapid fire session, so who is the volunteer? Anybody? Please unmute yourself and tell the name. I saw some names.
Dr. Altaf Hussain again.
Okay, Altaf. So who is the candidate for? Oh, sorry. I'm extremely sorry. I'm sorry that I messed up the thing. Okay. So who are the candidates for neoadjuvant chemotherapy? Quick answer. Dr. Altaf.
এখানে কোনো অপশন থাকবে না স্যার মানে
No, you answer.
Okay sir, all inflammatory breast cancer, all locally advanced breast cancer, any end to or any node positive disease, in case of TNBC or HER2 positive, any tumor more than 2 centimeter.
Wonderful. You have covered almost everything. So next question. So hormone receptor positive or negative, which one is a better responder for NACT?
The hormone receptor negative.
Good. So which grade of breast cancer responds better to NACT? Grade 1, 2 or 3?
Sir. Grade
Very good.
3.
So which type of breast cancer responds most to NACT? What is the best responder? Highest pathological, yes, triple negative breast cancer. How to avoid mastectomy in complete response? Yes, please.
Not triple negative. Triple negative is second highest. First one is HER2 positive.
No, triple negative is first highest. HER2 positive is second.
Okay.
I disagree.
Okay, we will discuss in the next session with our own data. So how to avoid mastectomy in complete radical response after NACT? What
hydrogen
precaution we should? Thank you. So, okay. Sorry.
এরপর থেকে অনলাইন খাওয়া দাওয়ার ব্যবস্থা করতে হবে।
Okay. So how many cycles of dual blockade of trastuzumab and pertuzumab is recommended as NACT? As NACT, you want to give dual blockade. How many cycles of trastuzumab and pertuzumab you want to give?
Total sir 12 cycle.
As neoadjuvant.
Sorry sir, I can't answer that.
Okay, 6 cycle. So how many cycles of CT should be given as, I mean, if you have a plan of 8 cycle, how many cycle of chemotherapy you want to give as a neoadjuvant chemotherapy?
8 cycle, total 8 cycle.
Yes, all planned cycle of chemotherapy. If it is 6 or 8, whatever it is. Which trial justified that all cycle of NACT is beneficial? NACP27 and Neosphere trial. So when immunotherapy can be used as chemotherapy with chemotherapy in NACP, in which group? We have discussed. Yes, please.
In case of triple negative breast cancer.
Thank you. TNBC with Taxol. Thank you. Thank you very much. So now, Masum, do you have the result?
Yes, sir.
Okay. Who is the winner?
Today's winner is Dr. Pujan Batoza. Dr. Pujan Batoza.
Dr. Pujan Batazu.
Sorry.
He's from Nepal.
He's from Nepal. Yes, I got.
Can we see you, Dr. Pujan?
Sir, assalamu alaikum, sir.
Walaikum assalam.
Switch on your.
And when we went to Nepal, good care of us.
Thank you, madam.
So I cannot see you. Your camera is off?
Yes, sir.
Okay.
If
possible, can you please on? We want to see you. We want to see the winner. Okay. So there you are. Congratulations, Pujan. So are you in Dhaka now or you are in Nepal?
So I'm in Dhaka now. We are going to Nepal on 17th of June, sir.
So I will make sure that before you leave, you should get the prize money. Congratulations again. So now, can you, Regan, I want to go back to my slide share, screen share. Yeah, please. Almost we are finished. So our next week topics is adjuvant chemotherapy in breast cancer. Our speaker is Dr. Shahida Alam. Our speaker is overseas guest will be Dr. Zakirullah Sheikh Farid Ahmed. And we are trying to keep John. We don't know whether it will be possible for him to be with us.
John, are you free this week, John?
Yeah, that should hopefully be okay.
Good. Thank you very much.
So now we are almost at the end of the session. So we are almost at the end. So can I ask that if anybody, I mean, out of the three faculties, do you like to make a very quick comment? We had some discussion already, but very quick comment from John, Zakir Bhai, and Farid.
I think 2 weeks would be better for me. What about Farid and John?
Okay. Somebody.
Okay, thank you. Well, I'd like to congratulate once again the club for arranging and continuing this excellent webinar. And I have to say, historically, neoadjuvant chemotherapy has been least practiced in certain parts of the world, like for example in Bangladesh. But in the last 10, 15 years, there is a change you can see. And it's because of this seriously educational and other practice led by oncology clubs. So really commendable job. And when it comes to the relationship with surgical perspective with neoadjuvant chemo, I would urge with all the oncologists, before you consider giving neoadjuvant chemo with a view to downstaging, please insert a marker clip. This is all available now, and I can tell you, even we've been practicing for 2.5 years in Bangladesh, but recently Cancer Institute have started practicing it as well. So please don't forget about inserting a marker clip in order to get the best benefit for patients with neoadjuvant chemo. Thank you very much.
So thank you, Farid. I think now we are almost at the end of the session. Now it is 4:33. I was supposed to finish it by 4:30. So let us be on time, because our founder, Professor Karim, was a person who used to be there on time. Masum, do you have anything to say?
Yes, sir. Yes, sir.
Yes.
Some of our participants are suggesting about some issues. So if I want to make some comment, after the session, we send a feedback form to all of you. So please fill it up and give it back to us. So it will be helpful for us and us to arrange our next session according to your suggestion. Thank you.
Thank you for Masum. Already the most very minimum response was the feedback, which is very important for our design. And we shall appreciate if you please give a feedback, and then which will be helpful for our designing of the future program. And we want to continue the program, and maybe after the next session, we will bring some radiotherapy topics in and surgery to bring some changes, because surgeons are feeling bored sitting with their knife, that they are not having any job. So we will be bringing them also in this picture very soon. And again, we are telling it is not a teaching session, it is a discussion session, it is a platform where we are all learning. And in oncology, nothing is absolutely right and nothing is absolutely wrong. But you must have a scientific evidence when you are thinking of something, that is evidence-based medicine. And don't forget the patient when you're taking a decision, because patient is a big player in the whole decision making. It is not us as to just give them a verdict that this is a death sentence. No, they are also part of the team member. And thanks to Haisar, be with us for all the full session. And we are very happy that your support is really encouraging us. Today, our participants went up to 60 plus, and even after 90 minutes, 50 plus. Just now it became 50 is there. So with these few words, sir, if you allow, I want to finish. Nasir Pissa, I heard you want to say something. We will talk later. Sir, can I finish it, sir?
Oh, surely, please.
Okay, sir. Thank you, sir. With your permission, I am going to finish it, and we invite you all to join our next session on next Sunday at 3 o'clock. Stay safe, be active, keep serving your patient, but don't forget your security. And finally, my apology for forgetting that Sumon was a front fighter, and he, our representative, and we hats off to Sumon, and we hope that he will be staying safe. Thank you very much.